Yes, sure. Hi, everyone. Welcome to our webinar tonight about exercise and sports. We are so welcoming Dr. Mariam Bagis. She's consultant family physician working with the Family Medicine Academy in making Fahad Medical City. Welcome, Dr. Mariam, and the floor is yours.
Thank you very much, Dr. Aisha. يعطيك العافية. مرحبا بالحضور and welcome to everyone who's attending this evening. Hopefully this webinar won't be too extensive. I'll be going a few common things, mainly definitions and what sports medicine is about, how hopefully we can guide our training, our practice and clinical methods to improve our awareness in exercise and sports medicine. Just to give a bit of introduction about myself. So my name is Mariam Hamad Bagis. أنا أصلا من الغربية. I graduated or I had my MBBS at King Abdulaziz University in Jeddah. I did my research at McMaster University and I'm a clinical research associate. I'm also a Canadian certified in family physician from University of Toronto, and I'm a subspecialist in care of elderly. الآن حتقولوا إيش دخل الإكسرسايز سبورتس ميديسين في الكير of elderly. There's lots to do with it. My niche or my subspecialty is more of geriatric spectrum. However, the exercise and sports medicine is a big umbrella and that affects all disciplines in medicine. And it's my honor to be presenting to everyone today. And let us just see how we can do this. Okay, hold on. So basically, what is sports medicine? I'm sure everyone has some idea of what it is. But just to kind of clarify what's the scope for this specialty, it's a specialized field of medicine. It typically manages injuries that's caused by exercising, whether it's recreational, so something that we all can do, or on a more professional level. So people who are participating in sports or doing types of physical activity at home or on a more professional level, as I mentioned. So it's also a field that works on preventing illnesses. So it's not only managing conditions as they come in, preventing them as well. And so there's primary, secondary, and tertiary prevention, which I'm sure is everyone is familiar with as family physicians. So sports medicine specialists also work with multidisciplinary teams that include physical therapists, physiatrists, athletic trainers, and nutritionists. These are on a more professional, more upper scale. However, sports medicine specialists can perform in a regular clinic, as we all do. So the next question I usually get from residents and mostly medical students, but sometimes residents who are interested in sports medicine, what's the difference between orthopedic surgeons and sports medicine? Obviously, there's a very big difference with the training duration. So orthopedic surgeons, there's more training, particularly with surgical procedures. Sports medicine, you could specialize without having a degree in some countries, in some regions in the world. However, هنا في الهيئة التخصصات السعودية, most North American regions, and I mention most because not all of them require a subspecialty, particularly family medicine and going into sports medicine. So there's a difference in training. When it comes to the scope, orthopedics and sports medicine both address similar conditions, but obviously they're different fields, as the orthopedics are more surgeons, sports medicine and non-surgical, typically non-surgical background. Orthopedics focuses on MSK conditions. Sports medicine can address concerns regarding MSK conditions and beyond. So they can look into cognitive aspects, nutritional aspects, and all other comorbidity or comorbid conditions as well. Orthopedics as well are trained in also surgical or operational procedures and clinical-based procedures. Sports medicine can definitely perform lots of clinic-based procedures. However, they mainly are the non-operative treatment of MSK conditions. Majority of sports injuries are non-surgical. So we can't send everyone who has a sports injury to the orthopedic surgeon. We don't have enough of them around. and their scope of practice is somewhat different. Same conditions, however different. So this Venn diagram it kind of represents what I was trying to allude to, which is family medicine. We have lots of the preventative part of the medicine. We manage common conditions, and orthopedic surgeons do lots of surgical OR treatments, procedures, and other. So they do all the MSK conditions as well. Physiatry, which is basically the physician who is trained. They have extra training in rehabilitation medicine, and they typically lead or would lead a rehabilitation program. So sports medicine would kind of be a specialized field, somewhat here in between. They're mainly from the family medicine background, but getting into that specific field. So just a little bit of a background on what how sports medicine came about. It is mainly an organic, it's one of those fields that organically came about because of the need. So when there's need, there's definitely a way to provide demand. So if there's a demand, there's definitely going to be a way to provide the service. So the concept is quite old. It's been around since the 5th century. So medicine has, so old medicine, the old age medicine has been looking at exercise and its effects on circulation. This is all the way back in the 18th century. As soon, so, you know, we all know around the year that the Titanic unfortunately sank. There was, or right before the end of World War I, Germany was already promoting. So this is pre-Nazi era. Germany was already promoting the Association for Medical Sportive Association to provide medical care for athletics. That's exactly when the Olympics started, around World War I. And right around, or right before World War II actually ended, which is when 1948, they had the first association in Germany for the medical outpatient department for sports. And in 1991, which isn't really that far away, the American Medical Society for Sports Medicine. So it's quite new. The concept is old. However, it formalized back in the 90s in North America, and it is a field that is growing in popularity as exercise, recreational, and professional is growing. So hopefully we're going to, well, let's talk about what the countries that are leading sports medicine, what they kind of look like. So sports is a household hobby that is everywhere. So there's lots of sports starting from KG all the way to, so they have, you know, softball, peewee, baseball. They have lots of dancing classes, cheerleading, dance classes. They have lots of after-school activities that involve sports. So these are for kids. And there's mandatory physical therapy classes. So there's lots of sports in school, in college, and post-college. There's recreationally as well, especially now with the boom of social media. Everyone's exercising, everyone's sharing their experiences and encouraging others to exercise, which is amazing. Particularly in North America, high school and college baseball and football are very lucrative, lots of money, lots of investments, lots of, so the players actually bring in money. So that's why they get free scholarships in lots of these colleges. So they're investments. So they actually invest into sports medicine departments. They invest into sports medicine physicians to look after their constituents and their students. So not only on a professional level, as I mentioned, I'm not even on an Olympic level. I'm speaking on your day-to-day average family. The daughter is in dance class, the son is in hockey practice, the dad plays recreational baseball with his friends over the weekend. And we're seeing this more and more in our culture as well. So we have more, kickboxing, more interest in other sports like heavy, weightlifting. So this is the Saudi Mahmoud Al-Hamid, he was actually qualified for the weightlifting for the Tokyo 21 Olympics. But there's even recreational exercises. So we know the effect of exercise and benefiting patients with chronic illnesses. So the point of this slide is perhaps other countries have advanced or I want to say maybe have adopted exercise in their culture, and we are in suit. So there's football, there's baseball, there's other recreational exercising regimens. So sports medicine will be a big thing in Saudi Arabia or in the Middle East in general. Very soon, I predict, inshallah. So this is just kind of just one slide on the benefits or the effect of exercise training on cardiovascular risk factors. As we all know, the #1 killer in the whole world, including developing and underdeveloped countries, is cardiovascular disease. And this is what I tell my patients every time in the chronic disease clinics and all my patients in the primary practice. It's very important to incorporate healthy lifestyle choices, healthy, regular activity in your day-to-day in your day-to-day living. So diabetes mellitus, there's very strong evidence that supports exercise. So dyslipidemia, hypertension, definitely cigarette smoking. It's an excellent replacement. It's an excellent aid for patients who want to quit smoking. Obesity, obviously, and psychosocial health. Exercising by ourselves or exercising with loved ones, going to the mamsha or going to so just having that exercise as a group activity as well is it's great for the dynamic of the family. So we already all know this, and there's lots of evidence to support this. As we encourage our patients to go into exercise regularly, we will face more and more cases in our primary practices, let alone so in the sports medicine department, let alone in our primary care practice. So it is coming, and it will be a big thing. So hopefully for those who are interested in sports medicine, you are the future. Nadrat 2030 is definitely pushing for improvement of primary care. We're pushing patients to be more healthy and active. So sports medicine is definitely something I think in the future will be an excellent subspecialty to go into. So the next portion of my talk is going to be about the common sports medicine conditions. I won't go into detail in all of the conditions, not today. I just wanted to touch base on some of the more common cases that we see in the clinic day to day, and some of the things that are common in the sports medicine clinic as well. How do I get rid of this? I'm sorry, hold just 1 second. How do I get rid of this? Okay, so the key to this part of the talk is whatever the case is, whatever the condition is, whether it's sports medicine. So as a primary care physician, this is still within my scope as a family physician. And we can always subspecialize in this, whether it's a niche in our practice or further training. However, the whole point of this couple of slides is always have an approach to for all of our conditions. So there's no spot diagnoses unless it's a clear cut. I want to say, for example, patients is coming in and asking if this is a eczema or a sunspot. Aside for that, it's typically there should be an approach to all our conditions. For example, this is from the American Family Physician for the approach to knee pain in adult patients. So obviously there's other causes in younger patients. So there's lots of types of, lots of causes for what that could look like. And this is again available in the American Academy for Family Physicians. And this is so there's a huge or a long list of differential diagnosis. Common is common, but try to keep some of the limb-threatening conditions in the back of your mind whenever you assess a patient. So we'll just tackle this portion with a case. And the case goes as follows. So it's a 35-year-old female, was recommended for regular exercise to manage her polycystic ovarian syndrome. I know I'm going to digress for a second. We all know that the number one treatment for chronic or metabolic conditions such as PCOS is exercise and weight loss, 5 to 7% of their weight. So we are recommending all other treatments in addition to regular exercise, and they are very willing and they're taking it to heart. She has been exercising. She's doing great. However, she returns to the clinic and she's reporting bilateral knee pain. So this is a common scenario. We ask our patients to go exercise. They come back. And sometimes, we're frustrated because we don't know what's going on. Or sometimes we do manage the case and we just, we don't manage how they move forward. And I'll tackle this moving down the line. However, so we recommended exercise. She's exercising regularly. And now she comes back with bilateral knee pain. So she has two choices: either manage the knee pain and continue her active lifestyle to manage her chronic conditions, or just stop exercising altogether and just stop exercising, gaining weight, and not controlling her cardiovascular risk factors. So obviously we want her to continue exercising. So first step is to diagnose what's going on. So her history will go on to mentioning that she has pain located at the anterior part of her knee. It's mainly exaggerated by descending stairs, so going down the stairs, kneeling, prolonged sitting with knees bent, so whether she's sitting on the floor or at her desk. I'm sure everyone has like bells ringing on what it could be. However, we'll just take it step by step. So obviously there's the differential diagnosis. I won't go through that. We'll just kind of go plow through and focus a little bit. However, I do really encourage everyone to have an approach, a systemic approach that will benefit them in their OSCE exams, in their clinic, in their day-to-day practice. So obviously, after taking a detailed history about the pain or where the pain is and what associated symptoms are and other red flags such as trauma, fever, and other causes that could be systemic like intra-articular arthritis, although it's not common. It commonly doesn't present bilateral knee, but it could. However, it's very, very rare. I haven't seen a case aside for a case study online. So the next step would be an exam. So obviously we want to observe how the patient is walking into the room. So the patient is walking in without limping. She is walking in comfortably. She's not supported by a walking aid or holding on to the furniture of the clinic or the rails. On inspection, the knees appear normal. There's no swelling. So the inspection requires practice. Some knees are typical knees, so there's no typical knees. I apologize for that statement. What I mean to say is knees look different. So you need to see 100 knees, 100 normal knees to know what is a normal knee and on inspection. So there's some knees that are a little bigger than others, especially in overweight patients, shorter patients, patients with known conditions. So you have to see hundreds of normal knees to know what's a normal knee or a normal joint or and so on and so forth. So on inspection, she appears to have symmetrical, bilaterally symmetrical knees, no obvious deformities, no patellar. So you want to examine the patient sitting and lying down if possible. If not, you can try to have them lying down. The patellars are nice and central. There's no swelling. There's no ecchymosis, which is basically bruising. And she's moving fine. So just observing them move their knee around is also another key in examining the joint. Obviously, you want to palpate you want to palpate the muscle, you want to palpate the tibia, the femur, the patella, and all the points in the knee. And again, I won't go through the whole details today, maybe eventually with the picture, but so palpation in active and passive range of motions and specific testing, which I might show a video of. However, I'll make it specific to the condition at hand. So in this case, it turns out that the patient has a patellofemoral syndrome, pain syndrome, or PFPS. It's quite common. We see it lots in the clinic, and it's actually one of the most common cases presented to the sports medicine clinic, or clinic where active patients go to. Common cause of traumatic knee pain common cause of non-traumatic knee pain. So it's very important to have non-trauma or no trauma in the history. and it is a common non-traumatic knee pain in the young. It can also happen in older patients, often occurs in women. However, it's not specifically to, I've seen it in my clinic, I would say about 50-50, haven't seen it specifically to women, but I have seen quite a bit in the clinic. Particularly active athletes can also have it. So active patients, athletes, runners, cyclists, and basketball players. So lots of jumping. So you're going to notice that lots of these, so active, especially going upstairs, doing inclines, high knee raises, jogging. So any jogging kind of activity or going up the stairs. Athletes, runners, cyclists, there are lots of pressure over their knees or the interior part of their knee. It is thought to be due to overuse and malalignment, and I'll get into that in a second. So patellofemoral pain syndrome is quite common, and it's good to know what to do about it and how to educate your patients moving forward. So imaging typically is not required. It's a clinical diagnosis, and it's based on the history. And the pathognomic part in the history is the interior pain that worsens with squatting, going upstairs, or kneeling. So when patients describe pain on prayer, for example, you can specifically ask which part of the prayer. Is it kneeling on your knees or getting up or squatting down for sujood? So even as patients describe their pain, it's very important to identify the mechanism of the pain. On day-to-day activities, and you can also, especially when they're playing. So for example, basketball players, they will tell you right before as I squat, right before I ready myself to jump and dunk the ball, that is when I get the pain, just that squat. So the squatting pain is pathognomic for patellofemoral pain syndrome. So this is the patella. So this is our femur here. I'm sure everyone's aware, everyone knows the anatomy. So I do apologize if I go over this very quickly. So here's our, this is our femur here. And this is our tibia, our fibula, our tibial tuberosity, which is basically the patella tibial tendon. And the patellofemoral tendon over here connects to the big bicep muscle. And this is where they naturally feel the pain. So on palpation, they don't specifically have any point of pain. So as we're palpating over the joint line, medial and lateral. We're palpating over the tibial tuberosity. We're palpating all over the lateral and medial meniscus, over the muscle, the bulk. We're not having any sort of pain. However, when we ask them to slightly squat, they will tell you this is where the pain starts. So that is for in case it was actually patellofemoral joint. So this is what this is what the patella looks like. And this is basically how it typically should be gliding in. However, when we have an there's more a tight quad and a stronger leg muscle, so lower strength, so more strength in the lower part of the extremity or the leg muscle or the al-batta على قولهم بالعربي. This tends to glide more internally. So for patients, for example, who have not been physically active previously and they have more of a stronger leg muscle compared to their thigh muscle, we typically ask them to strengthen their thigh muscles with home squats, and I can go over some of the exercise later on, before they start going into physical activity. So that's how a sports medicine specialist or someone who is managing a patient as a sports medicine case would approach, as opposed to just diagnosing the case and, okay, just go ahead and go home, take your NSAID and rest and the rice that we all know. They actually manage what is the cause of this injury and how do we prevent this injury later on. What would even be better if this 35-year-old lady, before going on to doing moderate to extensive exercising regimens, I can help her manage or define a plan to move forward. So we could do just an exam. I could encourage her to do more stretching and strengthening. So what stretching exercise does, it lengthens tense muscles. So for example, again, back to the case that I was mentioning, if they have a stronger gastrocnemius muscle, which is leg muscle, I will ask her to, and a slightly weaker thigh muscle, I'll ask her to strengthen her quads muscle so that the quad isn't too lax and there's an internal rotation to do the strength of the leg muscle. So then it'll move in a different direction, causing more pain due to the malalignment. The opposite is true. If the thigh is more stronger, for example, than the leg muscle, and then there could be more of a lateral or an outward malalignment for the patellar movement. So before anyone starts any exercise, before I recommend anyone to go to the gym or do any of that, it's very important to have a sports medicine approach, which is basically a family physician sports medicine approach, prevention first. If there's any problems that they have, so flat foot, have proper footing or shoe insoles. If they have tight muscles, to do more stretching, so they elongate the muscle so that it doesn't over tense and pull on and cause repetitive injury. Same thing for weaker muscles, to strengthen. So it's important to know the components of what home physical therapy looks like, or what I would expect from a physical therapist to do in order to prevent this kind of injury. And for that, so that this patient can go back to doing her regular activity. So now I've diagnosed that she has patellofemoral syndrome. I can just focus on, strengthening her quadriceps with squats at home, for example, static squats or isometric squats, or as she's holding onto a chair. Obviously, the other supportive measures like resting or modifying duties, so not full rest, however, modifying duties, icing 5 minutes, 2 to 3 times a day, particularly in acute stages, so the first 5 to 7 days post-injury. Analgesics, particularly NSAIDs. Obviously, I'm not going to go over the risks and how to counsel our patients with the NSAIDs. I do want to point out that solpadeine is very common amongst our patients, and solpadeine is basically a paracetamol, which has no anti-inflammatory properties, and it also has codeine. So it only manages the pain in some patients. Most of the time, the patients come back with dizziness, feeling nauseated, constipation, and no results. So just recapping what the whole point of this case is, it's not just diagnosing what the cause is. We want to prevent this from happening. So we encourage our patients to do stretching and strengthening exercises, particularly before going to the gym or having a regular high intensity exercise regimen. We want to diagnose what their condition is, manage it appropriately, and give them a timeline to when to return to exercise gradually and safely, so that they can maintain a healthy lifestyle. That's the whole point of exercise and sports medicine, is maintaining healthy, active individuals. So having a sprain, or for example, patellofemoral pain syndrome, we try to manage this so that they continue to be active, as opposed to stopping exercise altogether and going back to their inactive lifestyle. Okay, so what else could this case be? So what other causes? Again, so this is the case, just to remind everyone, it's a 35-year-old female who took our advice to heart and went ahead and went into regular exercise, and she's coming back with anterior knee pain. So what another cause for this could be, so anterior knee pain could definitely be a meniscal tear. The history of the patient doesn't suggest that. So it's very important. The mechanism of injury also tells me which part of the knee or which part of the anatomy is affected. And having bilateral meniscal tear requires heavy forceful twisting or rotating of the knee. So just lifting, so I know this is an example, so not only sports, but we can have active working adults who are lifting heavy stuff. And we always tell our patients to never lift with their back and lift with their knees. The key here is that they lift without twisting. So twisting is the main part. And again, for basketball players, lots of jumps, football players, heavy lifters or deadlifting. So lots of kneeling and potentially twisting is what could cause meniscal tear. It can happen in older patients for no good reasons, as do fragility fractures. However, it's not considered as a fragility strain. It just can happen in older patients, particularly who are inactive, not exercising or not stretching at all. So other causes of injury could be kneeling. So some patients, I've had two older patients in their I would say late 60s, just kneeling for prayer, and they had a meniscal injury. So never rule that out. You have to have an extensive differential diagnosis approach to any condition, even if it seems like it's an easy go-to point diagnosis. Deep squatting can definitely happen as well. Lots of, I've seen a couple of workers who actually come in with deep squatting injuries, lifting something heavy with twisting. So not only sports. So meniscal exam, I have a video here. So I thought maybe it would be better just to show a video of what a meniscal exam would look like. Meniscal exam, I've seen that not a lot of students or residents perform appropriately or perform at all. So it's good to know how to perform it correctly. And this is how to perform it on a laying patient, a patient who's lying down.
Assessing for any joint opening. We assess the integrity of the menisci, which are two C-shaped shock absorbers, which lie on top of the tibial plateaus, by applying a compressive and twisting force. So this is testing the lateral meniscus, and this is testing the medial meniscus.
So I'm just going to go back here 1 second. So I've seen a couple of medical students actually perform this, but they don't apply enough pressure to the foot. So what's happening here, she's stabilizing the knee. And I do apologize if I'm going over this slightly in detail. And I'm pretty sure everyone here is very competent with their knee exams. However, it's very important to know how to do it properly so that you can pick up any first-degree tear, any injuries to the meniscus, which is a condition that requires the patient to be offloading or not weight-bearing on that specific leg for them to have a full recovery, particularly in the acute and subacute phases. So what she's doing here is she's actually pushing it down. So so this is the medial side of the leg and the lateral side is on the other side. So there's a C shaped in the other side and the medial would be this way. So she's grinding the leg onto the lateral side by that motion. I'm going to repeat the video again. So again, for the medial side, which is the other meniscus, which is the half moon shape this way, she's grinding the leg the other way.
Meniscus.
So this is lying down. I'll just repeat that.
We assess the integrity of the menisci, which are two C-shaped shock absorbers, which lie on top of the tibial plateaus, by applying a compressive and twisting force. So this is testing the lateral meniscus, and this is testing the medial meniscus. Out, please.
Obviously, this testing is a little, it can be challenging to perform in the clinic with a heavier patient. Younger patients, I would suggest doing the standing test for the meniscal injury. So it's called the Tesley test. It's spelled as Tesley. However, all the sports medicine consultants that I've worked with all pronounce it Tesley, so I'll just continue and call it that way. So this is the easier part that you can do in the clinics, particularly with the younger patients who are willing to perform it. The other better technique would be asking them to squat, but most people won't do that. So you can actually just try this in the clinic. They will go over a technique and I will just modify that to make it more patient-friendly.
Check out our knee assessment playlist on the left. Meaning, asking a patient whether they have anterior knee pain while squatting is the best available test to date, as PFPS will be evident in 80% of people with this finding. But PFPS has to be seen as a diagnosis of
I'm sorry, I think I missed the part where he actually performed the test. Nope, not this one. I do apologize. So I'll just, just allow me to do it here. I'm sorry. I thought I had it. I was fine. This one.
To perform this test,
Have your patient stand on the injured leg, which is flexed to 20 degrees. Your patient.
So I'll just mention that always start off with the normal knee first. So in the OSCE exam, in real life, always start off with the non-tender or non-painful, whether it's an abdominal exam, whether it's a shoulder or knee joint exam, always start off with examining and knowing what the normal is for the patient. Obviously, if there's an asymmetrical injury or polio patient, that's a different scenario, or scoliosis, obviously that's different. However, generally people are symmetric, and you want to test for the normal part first before going on to the painful part. And this will also help the patients brace themselves or know what to expect when we're examining the tender joint or tender region.
Patient may hold on to your arms for support. Then rotate over the tibia 3 times on each side.
So notice how they're doing exactly the same thing. However, they're standing. You don't have to hold on to the patient. You can just stand next to them. Ask them to hold on to the chair, a static chair, so nothing with wheels, so they, in case they fall down. They can hold on to the table or the exam table. So they can put both arms on and then just stand on one knee, bend it for 20 degrees, and then ask them to lift the other knee and then twist. So it's more of a twisting motion. So obviously this side would be for the lateral, the other side would be for the medial. And if there is an injury, they would definitely feel some pain, or most of the time they'll tell you, no, I can't complete this test. So that is definitely a positive. I'm just going to check this. Okay. So that is for the meniscal injury tear exam. So yeah, so I took a few more minutes on that just because I think it is important and that we all need to know how to diagnose it properly. So that injury could have been easily a meniscal tear. However, the points in her history and her exam doesn't point towards that. If it's an acute or subacute injury, she will be limping. She might have some swelling to the knee joint. So there's obviously methods to pick up swelling or edema in the joint. And there's on inspection, and obviously there's the milking for mild infusions. Moderate infusions are more severe injuries, particularly related to 2nd to 3rd degree tears, or at least 2nd degree tears. 1st degree tears are quite common. They're not quite common, they're not uncommon is what I want to mention. So knowing how to do it properly and pick it up and manage appropriately is key. After managing, particularly in acute phase, whether most of the cases actually are managed non-operatively. If they need operations, they need referrals to surgical, orthopedics. And then managing the patients afterwards and encouraging them to have or to continue sports and an active lifestyle, despite having an injury, is again part of the scope of primary care, and particularly sports medicine. So keeping them active despite injury, picking them up early and appropriately managing. This is, so what if the case changed and it was a younger, let's switch the sex of the patient. It's a younger male in their 20s, or even a female in her 20s, and they're playing basketball, and she's coming in with, it could be either unilateral or bilateral knee pain, anterior pain. Could definitely be a jumper's knee. So jumper's knee is actually one of the most common cases that are presenting to the sports medicine clinic or clinics where there's lots of athletic patients, particularly playing sports, whether it's it could be more professional. However, I've seen this even with recreational basketball. So it's called jumper's knee or patellar tendonitis. So there's typically a tenderness with palpation. It's slightly different from the anterior patellar pain syndrome. There's no tenderness on exam typically. Patellar tendonitis is one of the knee conditions that can result in tenderness with exam. Sometimes there's swelling. Pain is not only specific to squatting, and that is also part of the history, and the mechanism is as well important. And it's usually caused by overuse of the knee joint. So the other picture that I showed you is typically the pain would be up here, or it's vaguely felt around the knee. They have very much difficulty in pointing where it is, when it's the patellofemoral pain syndrome. However, with jumper's knee, they can specifically point to this region. So this is your patella. Again, this is the tibial tuberosity, and this is where they would feel the pain. It's an overuse injury. The management is the same. So resting or modifying activities. It's very important to modify activities and not complete rest. Do activities as tolerated, anything that causes pain. Stop walking. They don't need extensive sick leaves. They actually need to stay more active. After this acute and subacute phase, they should definitely go into stretching and strengthening exercises, whether you can help them out with handouts from the clinic if you don't have a physiotherapist, or you can send them to a capable physiotherapist and specify. It's very important to specify strengthening, for example, quads, stretching iliotibial tendon. So it's very important to specify active physiotherapy, not passive. Passive is good with a pain management, but not on the long run. So it can help. So massaging, ultrasounds, heat and cold, these are all things that can manage in a short term. However, long term, and wanting them to go back into that active lifestyle and continue doing what they're doing, they need to get into active physiotherapy. And that, I believe that's another take-home message, because whenever I send a patient to physio, whether it's private or government sponsored, they usually come back and they're like, yes, the massage was great, the ultrasound or vibrating machine was amazing. However, the pain is back, and your your management wasn't good. So that's when I tell them you have to do active physiotherapy or send them to someone who's actually capable in doing that. So other knee conditions. So we all know the knee is a complex joint, lots of other organs. Again, this is back to the point of having a differential diagnosis and approach. When you ask the patient to point to where the pain is, so having a pain over here could definitely be something related to the biceps, or sorry, the quadriceps. I don't know if I've said biceps before, but what I actually meant was quadriceps. And so having the anterior knee, as I mentioned, it's more patellofemoral pain syndrome. Sometimes as the patient is lying down and relaxed, we can move or slide the patella over the trochlear. So moving the patella can actually cause pain, and this sometimes could be chondromalacia, typically in older patients, typically in bigger patients who are going into exercise right away without appropriately stretching, strengthening, and warming up. This spot here is quite common with younger males who are active in sports, and this would be the Osgood's ladder disease in the knee. So this is where the part, so if we change the whole scenario, it could have been an Osgood's ladder disease, which is or condition. So this is the patellar tendon. Its insertion is in the tibial tuberosity, and they could complain of pain over here, particularly in males who are 10 to 15 years. I've seen it up to 17 years. However, this is typically the age. I've seen more commonly in North America during my training over there. Lots of patients play basketball starting at a younger age, lots of jumping, lots of overuse injury, and it's typically managed conservatively. So in our community, we have more football or soccer, and they don't have this injury quite often unless they have lots of jumps, or يكون حارس المرمى, for example, or the goalkeeper, if they perform lots of jumps. But typically it's in people or boys who are playing more basketball because lots of jumping. There's more stress over the patellar joint to stabilize the patella over the knee as they jump and or ready to launch from the ground. Conservative management typically, however, if there's persistence, that is when we might suggest doing an X-ray. So we don't image any patient who comes in with knee pain. They are not all osteoarthritis. I've seen young ladies, 23 years old, diagnosed with osteoarthritis. So please have a differential, examine appropriately and manage appropriately, and encourage them to go back to exercising. So for this case, if it was a young boy who had persistent tibial tuberosity, tenderness, particularly after playing sports, after conservative treatment, rice for 3 to 4 weeks, modified activities, they're going back again, stretching and strengthening, and they continue to have symptoms. I'm more inclined to do imaging. So not all imaging will have something, but it can at least can show that there's a portion of the bone that's actually pulled. So there can be so much pull that it can pull away or pull apart a part of the bone. And sometimes surgical management. So in this case, I would recommend the patient to stop sports completely. So you're going to notice here the epiphysis is actually, so this is a younger boy. It could be 9 to 10 years old. This is a more grown, this could be after puberty, so it's already closed. So just that's the difference. There's no fracture here, or no fracture here as well. However, you're going to see here very faintly, there's a part of the bone that's pulled away. And similar here, this is a little more dramatic. There are more dramatic x-rays out there. Surgery sometimes can improve symptoms. However, this is the only case that would actually ask a 15-year-old boy to stop participating in basketball or participating in the sports that they were in and refer them to orthopedics. So there are some conditions where we actually have to stop our patients from performing sports in order to prevent more serious injuries. So for other MSK conditions, I'm not going to go over all of them. The point of this talk is not to go over every single condition out there. It was really just to go over the method or the critical thinking, the learning points, which if the only thing you get out of this is doing a proper exam and having a proper approach, it's the same old message from day one in medical school all the way up to being a consultant. If that's a take-home message and everyone takes that home, or 60%, I'm very happy with that. So if you want to read more about some of the MSK conditions, there are lots of resources out there. And I'll go over some of the exercises here. So there's the American College of Sports Medicine, so there's lots of information. And there's lots of CME information here as well. So this is for the American side. My go-to source for most of my handouts, I've worked with an excellent resident, Thuraya, Dr. Thuraya. We've translated some of the handouts into Arabic for some of our patients at home. We don't have access to physiotherapy in most of our centers yet. So we ask them to do home exercises, which is most of the time the best way to go about it if they can have it continuously and on a regular basis. So this is an example for knee rehabilitation exercises. And I like this handout because it also has teaching in it. It's for patients and for practitioners, and you know how to go about things. So it just explains to you which muscles they're working on, which muscles they're conditioning, the warming up, and how to warm up exactly. So they go into detail, which is great. For example, here are some stretching exercises. So there's the difference between stretching exercises. Again, it's lengthening the muscles for tight muscles. So lengthening muscles we stretch, and they tell you exactly how to go about it. There's some pictures here. There's lots of YouTube videos that can explain each and every one of them. These are stretching exercises. There's strengthening exercises. So these are some of the quadriceps exercises that I would suggest. You could absolutely modify it with a chair at home. So just kind of lifting or kickoff. This is for hamstring curls. So as we have bicep curls, we have hamstring curls. You can do the same with the squats with a chair, particularly for those who don't have great balance, not at the beginning. If there's any fear of falling for older patients, please do not ask them to do this at home, especially if they're by themselves. The worst thing they can have is a fractured hip, and they end up having poor outcomes over 5 years. So if there's any fear of, if they're on, they're older in age, they're comorbid, they're on anticoagulations or dual antiplatelet therapy, before prescribing exercise, please keep that in mind, that we want to prevent serious life-threatening or limb-threatening conditions before incorporating anything such as exercise. So having someone to supervise them, having it in a supervised environment like a physiotherapy or rehab setting or day program, which hopefully we will have here in the second cluster or in KFMC. So these are some hamstring strengthenings as well. So you can just choose one or two and ask your patient to do it on a regular basis. So if they have more of a weaker leg muscle, that will allow the leg to externally rotate, having the patella moving or gliding over the lateral part of the knee. I would focus on, for example, the legs. Vice versa for the thigh. If you don't know which one, just go ahead and ask them to do both. So there's no harm in doing both. So if they're stretching both and strengthening both, they're doing great. There's lots of other information for ankles and neck and shoulders. So lots of information in the American Association for Orthopedic Surgery. This is where this resource is. As for the other resource, sorry, I don't have it here. I'll just pull it up real quick. What is it called here? Sorry, University of Toronto Sports. They have lots of links to excellent sources. I don't know if this is clear to everyone. However, please go ahead and check it out if you're looking for credible sources. For example, let's go here for jumper's knee. For example, some X-ray images, some information for patients and professionals. Okay, let's just go back to our presentation. So moving on to another very common, not spoken about very much, not very popular between the, it's not popular generally. It needs to be more, we need to be more aware, we need to know more about, which is basically the traumatic brain injury. It's a very, very big shame that this is not incorporated appropriately in our schools, particularly schools for males or boys, as there's lots of I've worked 2 years before, so right after I graduated from my medical school, I worked 2 years in a general hospital, King Fahd General Hospital for emergency department. And I've seen so many traumatic brain injuries now that I look back. There was no systematic, so this was maybe 8 years ago, so it's been a while. I don't know if things have changed there or not. However, there's no a way to manage or pick up traumatic brain injury in our schools, in our emergency departments, in our primary care systems. And this is a very good field to go into, particularly for those residents who are still starting off their year. They're looking for a good research field to get into, especially if you're interested in sports medicine. This is something that you can, create evidence within your community. So the technical term is traumatic brain injury or mild traumatic brain injury. We all know it as concussion. So concussion in lay terms or basic English, according to the CDC, it's a type of traumatic brain injury and it's caused by a bump or blow to the head. So it can be a direct hit to the head, it could be a hit to the neck, or it could be to any part of the body that will cause a rapid movement back and forth of the head. So something like whiplash. So you can definitely have concussion with whiplash injury, even if the head does not hit an object directly. So this is key. All my USMLE exams, I want to say my Canadian board exam and the Canadian, the OSCE exam as well, all of them contained one form of the other of a concussion question, where the patient had a concussion without having a direct hit to the brain. So the reason why this is incorporated into exams is, and I think it should, it could be the case right now, I'm not sure. However, it's very important to be aware that concussions can happen without direct hits to the brain. It is key. I've seen this overlooked or underdiagnosed in emergency departments, in primary care settings. It's ruled out just because there's no head injury. So I've taken a few minutes just to stress on that because it's very important. And any sudden movement that can cause the brain shake, so that kind of shake can cause chemicals to change in the brain, neurotransmitters, stretching, and damaging brain cells. The technical term, as I mentioned, is mild traumatic brain injury. However, in the ICD-10 criteria, it's called post-concussion syndrome. And I'll talk about post-concussion disorder. And again, the point of me going through all these definitions is if you're interested in this field or you would like to read more on this topic, you will find that the names will change. However, they actually mean the same thing. Slight differences, but they kind of mean the same thing. And since most of us are still using the DSM, the diagnostic psychiatry manual for obviously now the 5 is out. However, it's good to know the differences. If you're doing any literature review, if you're doing any reading on the topic, it's good to know what they are. So post-concussion syndrome, the Americans or the ICD criteria is a history of head trauma with loss of consciousness. Now notice here, then the ICD, they're requesting that the criteria has loss of consciousness. Not all cases requires loss of consciousness to have a post-concussion syndrome. However, ICD criteria requires it in their definition. And it precedes the symptoms by maximum of 4 weeks. So having a head trauma 3 or 4 months ago and me developing symptoms today, it does not necessitate a post-concussion syndrome or concussion diagnosis. In addition, it needs other symptoms, which I will go over in detail. You can read this at your leisure. I will go over this again. There's pictures and other slides to make this more clear. However, the only part that I want to go over is they're requiring loss of consciousness. The DSM-4, I'll go over both 4 and 5 because some material are still following the DSM-4. It's good to know both. It's again, a head trauma causes significant cerebral concussion. There's no mention for loss of consciousness. So the patient can have it or don't have it, and it still can be post-concussion syndrome. And I'll talk about the neuropsychological or cognitive psychological criteria. And the DSM, however, they are requiring that as a neuropsychological testing. There are some specific testing, so we're not talking about the MMSE or the MOCA, which is validated for testing cognitive functions and memory in older patients. There are other testing for sports medicine. There are other testing that they, based on institution, based on the type of sport. So depending on where you are practicing, there are some neuropsychological testing. However, this is typically not used on a on a day-to-day basis in the clinic. History is good enough. Again, so they require lots of other symptoms, which I will go over in detail. The symptoms it should follow the onset. So the symptoms the onset should follow the head trauma. And they don't specify the time, but however, it's usually typically within 4 weeks. So the sign and symptoms, just to break it down to everyone: physical, cognitive, emotional, and sleep related. Physical is something they actually feel. So I just took this actually from the parachute.ca, which I will talk about in a bit. It's a great resource. I could be biased. This is what I was trained on. So this is my go-to resource for concussion, particularly in kids. They have information for kids and grown-ups and adults, but this is my go-to. You can have your own reliable resource. This is one that I would suggest. So the physical part, they would complain of a headache. So after having a traumatic brain injury, whether it's a whiplash in a car accident, or they were playing football, a goalkeeper was trying to catch the ball and he hit his head on the goal post. He didn't lose consciousness. no retrograde amnesia, no current amnesia, no no amnesia prior to the moving. So there's no amnesia before the trauma, during the trauma, or after the trauma. They can have plus or minus loss of consciousness depending on which criteria you're looking at. There's no red flags, nausea, vomiting, and all others. But however, they are now, after a few days, the parents are bringing the kid into the clinic. They're saying he hit his head a few days ago, and now he has a headache. He describes it that like a pressure, maybe plus or minus dizziness, maybe nausea. The difference between obviously the vomiting here is that if it's projectile vomiting, then that's not a good sign. That's a red flag. Blurred vision, sensitivity to light or sound. So it kind of looks like a tension headache. It kind of has the migraine feel. Ringing in the ears, so some vestibular signs, balance problems, feeling tired or low energy, drowsiness, or don't feel right. These are some of the physical signs that the patient can present with, one or a few. The criteria go, the ICD says at least 3 of any of the following signs. So the cognitive signs are something related to the way the patient is thinking. So they can report that, they hit their head on a Sunday, they have school and they haven't been doing well in school. They're not able to, manage their math homework, although they were fine the week before, but now they're having difficulties in just a simple equation, not thinking clearly. The parents could feel frustrated. You hit your head, you're dumb because you don't know, I'm asking you to do this for me and you're not thinking straight. So this could be a sign, and it's very important to educate the teachers and the parents that, this could be signs of a concussion, or else they won't bring them in. And this is the key point in educating schools and sports programs. So not thinking clearly is a big thing. Feeling slowed down, feeling like there's a fog. So some patients can just explain it as حاسس إنه في أنا مخي تحت الموية ماني قادر أفكر زي الناس. Problems concentrating and memory problems, not remembering what they remembered a couple of weeks ago, for example. They memorized Surah Al-Kafirun, for example. Now they're having difficulties remembering all the verses. So the third category is emotional. So they're easily irritated, they're sad, apathetic, feeling more emotional. So labile effect, they're very happy or very sad, they cry, or they're just flat affect. The last category is sleep related. So easily upset or angered, sadness. Oh, sorry, I believe this is wrong. So I think I had this. So I didn't change this. However, it's sleep related. So they're having difficulty in sleeping. They're waking up multiple times throughout the night, or I apologize. This is actually similar to the last slide. But they would typically either sleep too much or sleep too little, or having difficulty falling asleep or maintaining sleep. So they're having sleep-related issues. So those are the 4 categories of symptoms that could be related to concussion or post-concussive syndrome or disorder. Sorry, I pointed out that the ICD is the post-concussive syndrome. The DSM-4 is the post-concussive disorder. So I don't know if that makes any difference, but however, if you look it up, don't be alarmed of the different names. So the red flags, obviously, so the mild traumatic brain injury, you need to rule out these before diagnosing a concussion, and you don't need imaging typically for it. You will image if you're suspecting any brain bleed based on your history and examination. So you need to do all your cranial nerve exams. You have to make sure that the patient is, your basic neurological exam. However, when it comes to the red flags, no neck pain or tenderness, cervical trauma, whiplash could definitely cause cervical fractures, double vision. So this is a cranial nerve disorder. So definitely I would image that patient. Weakness or tinglings, so focal neurologic deficits, severe or increasing headaches. So the headache is increasing in magnitude. I would definitely need to rule out an intracranial hemorrhage. Seizure or convulsion, again, intracranial space occupying lesion, maybe hemorrhage. loss of, particularly if they have an underlying aneurysm. So just a small head trauma can cause that. So having that in your differential diagnosis, again, is very important. Loss of consciousness, we're talking about knocked out. So there's two types of loss of consciousness. When someone says "Ughma alayya" or "Ughma alayh," or they passed out. So you need to ask the patient or try to discern from the history that they didn't lose full consciousness. And most of the time they will say, I do hear them calling out my name. I'm not, I can hear them, but I feel like I'm asleep, but I'm hearing them. So that is not full loss of consciousness. And that is very important to differentiate for the red flag. So full loss of consciousness for an extended period of time, obviously, is a red flag. Deterioration, conscious state. So that's an obvious neurologic deficit. Vomiting more than once, particularly if there's no nausea. So if we're talking about projectile vomiting, there's more than 2 to 3 vomiting per day after the head trauma. That's a thing that we need to worry about. Increasing restlessness, agitative or combative. Again, that could result from frontal. So that could result from cerebral contusions. So contusions can happen anywhere. So it's basically a bruise on the brain that is a red flag. That is not mild traumatic brain injury. And growing confusion. So again, a few minutes over the red flags because it's super important. And if you need to make sure that this is part of your exam, part of your history on documentation, and referring the patient appropriately. If there's no red flags and the history is straightforward concussion, I wouldn't waste the patient's time or irradiate them for no strong indication with multiple CTs and unnecessary hospital admissions, unless you're in a rural area or you're dealing with low health literacy, so parents with low health literacy, you're really worried about the patient. You're not sure, you're not confident that the parents are, despite educating them, giving them handouts, no one's going to fault you for sending them to an institute or an emergency department just for some observation. However, we can't do this for all our patients. We can't do this for all our kids. And it's best handled in the primary care setting if we can avoid secondary and tertiary hospitals. So when it comes to the concussion management, the best evidence, again, back to for the patient outcomes is patient education. Whether we're educating them on how to manage their condition at the moment, and this is very similar to, again, some of the MSK conditions that we mentioned before, telling the patient what to expect and how to manage and why. So the best evidence, so just spending some time with our patients and explaining to them will prevent them from rotating back into the clinic, rotating to multiple private sector emergency acute care centers, going to other hospitals multiple times, just giving them that reassurance, giving them that appropriate follow-up and appropriate strategies to move forward. That is the best evidence and best bang for your buck. And we'll talk about return to school or return to work strategy, return to sports strategy, which is a completely different strategy, different timeline. Pharmacotherapy, which is we typically don't use right away. We kind of manage based on symptoms. So if there's headaches, we give paracetamol, NSAIDs, depending on their comorbidity status. Typically, these are young, healthy adults. So having NSAIDs, paracetamols to manage their pain, their headaches is not a bad idea. Giving them antiemetics if they're nauseated, and so on and so forth. Cognitive rehabilitation, this is not available here, but it's good to know that it's out there. There's something called cognitive rehabilitation, particularly for patients who are having cognitive problems over. Let me just take a step back. Most patients going through mild traumatic brain injury or post-concussive disorder / syndrome, typically they have full recovery anywhere from 4 weeks up to 3 months from the injury or the date of injury. They can have full recovery. Some patients, unfortunately, there's some studies say that up to 15%, some of them, depending on the sport and depending on the injury, It could be chronic. And for some of those patients, they will have long-lasting cognitive impairments, maybe memory difficulties. So these patients can benefit from cognitive rehabilitation, where they give them compensatory strategies to manage these specific cognitive difficulties. For example, if they have difficulty memorizing numbers, just have them written down or have them saved in your phone. Just have it a habit of writing them in, saving them in your phone. If you're forgetting your dates, have a big calendar hanging over your your door, your bedroom. So just giving them rehabilitate or kind of compensating for what they are not able to do it post-injury. There's psychotherapy, obviously, that can help with patients who will have chronic depression. Some patients will have PTSD after the trauma, particularly if it's a bad event, such as there's a big study with the veterans. So Army personnel who had suffered brain or mild traumatic brain injury in war, they can have that. Oh, sorry. I'm just seeing this right now. I do apologize. So I'm just going to wrap up real quickly. There's oculomotor and vestibular disturbances, and there is rehabilitation for this. So for folks who are interested in doing fellowships and training abroad, these are things that you will definitely come across. So I do apologize. I think we're running out of time. So I'm just going to go over this really quickly. You can look this up. So there's return to school or return to work strategy. The key here is that there's stages. And the first stage is basically activities at home. So we basically ask them not to do anything at all. So if you're going to sprain your ankle, you're going to stop dancing or playing on or standing on your ankle. It's very similar to a mild traumatic brain injury. You're going to ask your patient to stop doing any brain work. So no playing video games, no screen time. You can have anywhere from 5 to 15 minutes. However, you should stop if there's any fogginess, headaches. This is key. So if you have a patient who's coming in with concussion, this is absolutely 100% important, and it's proven to help decrease the symptoms. It's helped improve outcomes for these patients, particularly kids. So kids who are coming in with a concussion after playing sports or being involved in any sort of activity that causes a brain injury, this is very important. So giving them appropriate time off school. School boards obviously need to be aware of this as well, and they should allow kids to, for example, if they had a concussion and it's exam time, they should give allowances to kids to take time off school, delay their exams to another time when they are fully recovered. So they cannot do any sort of cognitive activities in the first stage. Depending on how their symptoms improve, they can start school activities. However, there is زي ما تقولوا تفاهم or cooperation between school and sports medicine or primary care provider to allow the kid to go back to gradual work, in class work only, no homework, so nothing that will excessively load the cognitive abilities of the patient. And there's return to school gradual. So again, it's in stages. You can go over this in detail. There's lots of information about this online. You could absolutely use this for your research study, how aware patients are about this, how aware school personnel about this. This is an excellent topic to start your research study if you haven't done so. So there's a return to sport strategy as well. So this is also applied to working. So if I'm a doctor and I went jet skiing and I had a head trauma, then I should be able to take time off to avoid any long-term post-concussion syndrome, having headaches for the rest of your life, or having apathy, mood disorders, sleep disturbances for the rest of your life is very debilitating. So having better outcomes is really key. And this is why detecting, managing, and educating is very important, particularly with concussion, particularly with kids. So grown-ups can have this as well. Return to sports. So for those who are, they're coming from a poor family, particularly in North America, they come from a low upbringing, low income, they go into sports, they're very good at sports, they go into college for free education, they're able to provide for their families. So they are the last persons on earth to want to ever stop going back to sports. So it's very important for these universities as well to invest in these so they don't want them to stop sports. However, they need to go back responsibly, and you can review this on your own time at another time. I do apologize. I know I'm going over the time. So this is my last slide. So again, most athletes will sustain a concussion, or kids. So they can have full recovery within 1 to 4 weeks from injury if managed appropriately. A small unfortunate number will continue to have symptoms. So in your assessing your patients in the clinic with chronic headaches that they didn't have before, depression, sleep problems, PTSD, always ask for that head injury or whiplash injury that could have been the cause of this whole cascade of symptoms. And there might not be something specific that you can do aside from maybe sending them to a sports medicine specialist or physio or cognitive rehab or neurologist. However, in educating the patient on why they have their symptoms and how to live with it and manage can help them a lot instead of revolving into clinics and hospitals. So DSM-4 actually mentioned that mild brain traumatic injury can resolve anywhere up to 3 months. So that is good and bad news. So again, summary, sports medicine, old concept, but it's modern and it's growing in specialty. It's growing here in Saudi Arabia. If you're interested in it, you like sports. They make good money because they do tour with the team. So they don't only manage injuries, they also do all the other prevention things that we do on a day-to-day basis as family physicians. They do vaccines. They look into cholesterol, all our adult screening. They look into maintaining the health of athletes. It's a need, and the specialty is growing, and there's definitely a big need for it and demand. There are common conditions in sports medicine. It's good to be familiar with all of them if you can, but most, and know that when is it surgical, when is it non-surgical. Small portion will require surgical intervention. Those are very easy to determine, and when to send to referral, so to manage the resources. And obviously concussion is the big topic. So thank you very much, everyone. I do apologize for going over time. I thought I was under the impression that we had 2 hours, but anyways, I'm done. So it's an hour and a half, and it's 8:30. Is there any questions? Is anyone still awake?
Thank you, Dr. Mariam. Thank you so much. It was very interesting, nice topics. If there is any question, just you can raise it in the chat. Or
Thank you. Sorry, I stopped.
دكتورة هو ما في عندنا هنا في السعودية سبورت ميديسن بروجرام صحيح؟ وتبع الرهاب؟
ايوه على حسب علمي دكتورة عائشة ما في.
هو الرهاب ما عندهم.
So
physical therapy.
So the common practice دكتورة اللي يصير لما يكون في traumatic brain injury يرسلوهم على الطوارئ to rule out any red flags or red flag causes، بس فعليا ما في. يعني ممكن بعض النيورولوجيستس لكن حتى النيورولوجي they're more geared towards cerebral vascular accidents, but not specifically to a concussion للأسف. Traumatic brain injury is a big slept on topic. Very big.
هو it's mixed because it's between the ER and the neurology and physical medicine, and the ER هم part of their specialty is trauma. Maybe that's why it was missed. Very interesting. Thank you so much.
You're
Myself,
very welcome.
I've learned a lot. Let's see if there is any questions, or I know we are. There is. Thank you, Doctora. People are saying thank you.
يعطيكم العافية جميعا.
Thank you so much. It's a pleasure that meeting you and hear from you tonight, Dr. Mariam.
يعطيكم العافية. والله شرف لي دكتورة عائشة.
الله يحفظك. لا we have to meet إن شاء الله very soon. طيب يا جماعة تصبحوا على خير جميعا. شكرا دكتورة. It was very nice, very interesting.
شكرا وأسفة على الإطالة. شكرا
لا it was interesting. أنا عن نفسي يعني مرة كنت أسمع بشغف على قول.
يعطيك العافية. شكرا لكم والله على صبركم وحسن استقبالكم.
يحفظك ربي. See you إن شاء الله soon.
Thank you, Dr. Mariam. If you could just give me your slides, I can share it with other participants as well.
excellent perfect لأنه فيها sources حلوة. طيب
أيوة طيب دكتورة بعدين أنا ممكن through فيكي أخذ رقمك إذا ممكن.
أكيد طبعا.
So we have in contact يعني.
We have a question regarding fellowship opportunities abroad.
في الفellowship again أعتذر إذا I'm taking over time لكن بالنسبة للfellowship abroad in the States there's an opportunity might be there's more, so just a quick difference between North American في كندا الاختبارات أسهل وموجودة sports medicine and it's under the umbrella of enhanced skills program. If you type in في Google enhanced skills program or sports medicine في Canada, getting into a fellowship is slightly or somewhat easier than getting into a residency. الاختبارات أسهل لكن opportunity أقل لأنه there's less seats. There's definitely less seats لأنه these programs are taxpayer funded فبالتالي هم حيدربوا اللي عندهم أول عشان هم ياخذوا for their own benefit. One or two positions every other year ممكن تتوفر للفيزا residents اللي هم أو الفيزا trainees اللي هم يعتبروا من خارج كندا. هذه في كندا. So everything is slightly more easier except for the positions أو chairs فتكون أقل. في أمريكا on the other hand they have more bigger opportunity. هي قارة كبيرة. It's coast to coast and they have more and the training programs are not limited to academic hospitals. يعني حتى community hospitals فيها training programs و they rotate in regions فبالتالي عندهم more seats و there's a higher chance of matching. However the USMLEs أتوقع هتكون على حسب اللي سوى USMLEs سهلة بالنسبة لهم يسووا step 3 لأنه step 3 على فكرة اللي يبغى fellowship only they don't care as much. هذا اللي أنا فهمته يعني don't quote me on this but they don't care as much على السكور اللي step 1 2 and 3 and I actually encourage حتى اللي ما يبغى إذا I don't know if you have extra time but doing just the step 1 and 2 and 3 is an excellent way to review basic science and incorporate it into your current practice. It's I did both and they help significantly with how you deal and manage with cases in your clinic. However, when it comes to fellowship opportunities, يعني ترمي يعني basically having both opportunities open to you is great. اللي فهمت إنه أيضا في اليوكي في أستراليا بس أنا عشان ما يعني ما أكذب عليكم I don't know much about what's going on how to get sports medicine في UK. أنا سمعت إنه أيضا it's easier than going all the way to North America. وأيضا في أستراليا because it's one of the Commonwealth countries as well and they have the Royal College as well so they have it as well in Australia. ما أدري.
Is there a residency ولا بس fellowship?
So sports medicine it's a stream أو زي ما تقولي fellowship للفاميلي medicine. زي الفاميلي medicine الآن ممكن يدخل sports medicine وهذا هو المعتاد. والER
طيب؟
الER ما لهم sports medicine because sports medicine هي it's a clinic based. يسووا procedures في الكلينيك they follow up in the clinic. أحيانا يكون لهم community involvement. الطوارئ ما يسووا كذا و it's not part of their يعني they can't يعني as a family physician in North America أنا ما أعرف عن UK بالأمانة وأستراليا لكن في North America as a family physician I can specialize in geriatrics which I have. I can specialize in sports medicine which is I've heard of this even before I like طلعت Canada so and you can subspecialize in maternity and child well-being. Adolescent medicine is another specialty for family medicine. Sports medicine زي ما ذكرت و there's quite a few branches للfamily medicine to get into لأنه even sports medicine in its essence it's treating the patient not just the knee or the back or it's managing the patient as a whole. Prevention is big part of sports medicine, preventing injury and preventing secondary injury. It fits very well مع family medicine.
اوكي طيب شكرا لك دكتورة. anyway يعطيك العافية وشكرا للجميع ونشوفكم إن شاء الله على خير ومساءكم سعيد.
يعطيكم العافية جميعا.
مع السلامة. مع السلامة.
Good night everyone.
شكرا فيكي. Thank you so much. Bye.
My pleasure. Bye.